Hi, this is Elliot Fishman, and you make the call. What you make the call is, I give you one slide, which are two images, and you tell me the diagnosis. So very, very focused. Let's get started. Patient presents with back pain, suspected dissection. When you look at these images, you don't see an aortic dissection, you see a paraspinal mass, and on the sagittal views, you see collapse of the upper vertebral bodies around T5 in the spine. That's a gibbous deformity. What is this paraspinal mass? It's inflammation, right? So what's your best diagnosis? Osteomyelitis. Osteo can present with severe back pain and can present as a dissection. Again, if you had a chest x-ray, you might see a widened mediastinum, again, suspecting a dissection or even adenopathy. A very nice case of osteomyelitis at T5, and with this gibbous deformity, it was due to tuberculosis. Right lower quadrant pain. There's a mass infiltrating the cecum, extending near the terminal ileum. It's bulky. This is not the look of Crohn's, is too thick. This is a malignancy. Could be adenocarcinoma, that's a possibility. It could be a sarcoma, but most typically the rest of the bowel looks okay. It's in the cecal region. You got to be thinking about lymphoma. And what was the diagnosis? This was B-cell lymphoma. A really nice example, bulky infiltration of the cecum, may involve the terminal ileum as well. A B-cell lymphoma is going to be your best diagnosis. This patient presented with what looked like small bowel obstruction on an abdominal x-ray. When you look at the images, you see dilated small bowel and you track it toward the right lower quadrant and to the left lower quadrant. In the left lower quadrant, you see what looks like a defect through the muscle. And you can see it very nicely, again, when you look at the coronal view. Right here, it looks like a knuckle and would be palpable on physical exam. What is that? That's a Spigelian hernia right through the muscle bundle. When we talk about small bowel obstruction, we talk about adhesions, we talk about tumors, we talk about midgut volvulus, but we also talk about defects in the abdominal wall through trocar sites or specific locations like a Spigelian hernia. A very nice case. This patient, a week after colonoscopy, had severe abdominal pain. Now with colonoscopy, you can perforate, right? You can exacerbate inflammatory disease. You can injure the spleen. There are a number of things you could do. If you have a biopsy, you could bleed. But this looks like a cystic adnexal mass. Could it be just a perforation and an abscess? That's a possibility. But this is coming off the left adnexa. And maybe it was a coincidence. This patient went to surgery. And this was a torsion of the ovary. There was a serous cystadenofibroma there. Well, maybe that colonoscopy just twisted it enough to cause that problem. Very unusual, but that was the diagnosis. Patient presented with left lower quadrant pain, suspected diverticulitis. When you look, there is thickening of the descending colon, but look at that inflammation near the colon. There's a soft tissue mass with haziness, and I don't really see any diverticuli. What things can simulate diverticulitis? Well, obviously ischemic bowel can do it, but one of the classic things is an appendix epiploica, right? And this is appendix epiploica. You see the thickened bowel, you see the inflammation, the haziness, the soft tissue mass. Right there, beautiful example of appendix epiploica. It's important to diagnose because this is treated conservatively with antibiotics, and the patients will do well. They do not need surgery. This patient presented with small bowel obstruction. When you look proximally, the bowel looks okay, but on the right-sided image, look at those loops of bowel. They're all really dilated. They're also not enhancing. I'm only giving you two images, but this is the classic look of an internal hernia with a midgut volvulus. Dilated bowel, no mucosal enhancement, and bunch of loops layering on top of each other. This patient went to surgery, had bowel resected. The bowel was ischemic, and it was due to adhesions, and then you get that very nice midgut volvulus. Very classic case and a very important diagnosis if the patient is to survive. Incidental finding, well, it's a left adrenal mass. It has some macroscopic fat in it and punctate calcifications. Yes, you can say, how do I know it's not adrenal cortical carcinoma? They can contain fat and calcification, but it's very well defined. And when you see fat in an ACC, the lesions are typically very vascular and very aggressive. This is a benign looking lesion. It's smooth margins, macroscopic fat and calcification. This is a classic appearance of a adrenal myelolipoma. Yes, myelolipomas can be all fat, but myelolipomas can also have minimal fat. If they're over 5 centimeters, they'll typically be resected because of the chance of spontaneous bleeding. What about this case? On the non-contrast or bilateral adrenal masses, you can go from adenomas to metastasis to lymphoma to pheochromocytoma. On the image on your right, they're very vascular. Now I'm stuck with two things, metastasis or pheochromocytoma. I know it's unfair because you only have these two images. You see the left kidney, you don't see the right. The right kidney had been removed, and this was metastatic renal cell. Renal cell and hepatoma are the two most common vascular mets to the adrenal gland. Yes, if the kidney was there, pheochromocytoma would have been a really good possibility. Very nice case. Abdominal pain and bilateral adrenal masses. They're large, minimal enhancement, but they're solid. They have the adrenal form but are huge. Yes, you can think about metastasis. Hepatoma gives you large mets, but they're usually round and somewhat vascular, not this adrenal shape configuration. When you see very large adrenal glands and they're bilateral, the diagnosis is going to be adrenal lymphoma. It's uncommon, but it's a classic diagnosis and a very, very important diagnosis to be able to make. Right flank pain and a large right adrenal mass. You can go through a differential, but the mass is over 8 centimeters. Faint calcification, mottled enhancement. Yes, it could be metastasis, theoretically a pheo, though that's unlikely. Adenomas, theoretically, but I'm not calling anything an adenoma that looks like this. To me, this is an adrenal cortical carcinoma till proven otherwise, and this was an ACC. Large mass, solid, somewhat necrotic. Again, with ACC, some are very vascular, and some, like in this case, are relatively avascular. Well, that's a bunch of cases. Hopefully the discussions help you. Hopefully the single pair of images made you think deeply. And hopefully you learned something. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.